Well, welcome everyone to the EKG case for the week of February 9th, 2012. This week's case is, just like last week's case, sent to us by a former graduate. Let me just say that if you have any great cases that you want to send that you'd like to share with the rest of the world, please send them to me. There's my email. That's why I put my email there on the first page. And I always ask for permission before posting these cases, so I'm not going to post any case without your permission. And I always make absolutely sure to remove any patient identification, and I won't even mention your name if you don't want me to. So some people don't want me to mention their names, and some people do. This case was sent to me by a former graduate from our emergency medicine pediatric residency program, superstar graduate and currently faculty member at Carolina's Medical Center residency program in emergency medicine, Dr. Sean Fox. Carolinas, for those people that may not know, is also the home of some other really, really smart people. Dr. John Marks, who is the current editor-in-chief of the Rosen textbook, and also Mr. PE, Dr. Jeff Klein, the guy whose name is on just about every PE paper in existence, and also critical care guru Dr. Alan Hefner. For some reason, I always want to call him Hugh, but his name is actually Alan. He's a really great guy. I've worked together in some critical care resuscitation courses, and a lot of other really, really smart people down there at Carolina. So thanks to you all, and especially thanks for Sean for sharing this case with us for this week. So they recently had a 48-year-old man who came into the emergency department with some atypical chest pain. And I won't go through the details, but suffice to say that his pain was, well, it was atypical. It wasn't the kind of pain that you're really worried about. And as a result, he got parked in the hallway on a really, really busy day. But most people that initially glanced at this guy and took a quick history were not that worried about his chest pain. He did have a couple cardiac risk factors, maybe a little hypertension, and he smoked some cigarettes, but no prior history of heart attack or anything else like that. And so on this very busy day, he got put in the hallway like many, many of us do in every emergency department around the world. We are using our hallways an awful lot. And anyway, here was his initial 12-lead EKG. And Sean did not initially see this, but some other folks did, and this is a pretty unremarkable EKG in a guy who's got very non-concerning type of chest pain. And, you know, even in retrospect, you look at this EKG, there's really not a whole lot going on. You know, maybe you can imagine down here there's a little bit of ST depression, but you know what? There's a little bit of artifact also, kind of a wavy baseline. So we're not going to make anything of this. I would call this EKG normal. There is just a little bit of J-point elevation, and we're going to call that benign early repolarization. We're not that worried about it. There's no reciprocal changes. Also, the other thing that makes us feel a bit more comfortable about that tiny bit of J-point elevation is that the ST segment is concave upwards, and that's worthy of a teaching point right there. When you see concave upwards looking ST segments, that oftentimes excuse me, that oftentimes should make you feel just a little bit more comfortable. It doesn't rule it out cardiac disease, but it certainly is reassuring compared to ST segments that are more straight in appearance and definitely more than ST segment upwards in appearance. Now, V1 has kind of a straight appearance, but you oftentimes can see that in V1. So you know what? I'm not even going to pay attention to lead V1. V2, V3, V4, those are all fairly not that concerning. And again, you can always imagine something in every 12-lead EKG. I look at this and I say I'm not that worried about that 12-lead EKG. So anyway, let's move on. This EKG was obtained at around 2:24 p.m. Now, they did look at this, and I think maybe they were looking out here laterally at some of these ST segments. There's just a tiny, tiny bit of ST depression, maybe, you know, less than a millimeter, so this would be considered non-specific. If it's less than a millimeter elevated or less than a millimeter depressed, that's considered nonspecific. That's what the term nonspecific means. If it's more than a millimeter, then you need to worry about it. But nonspecific refers to ST changes that are less than a millimeter. That's how the computer reads it also. All right, so, well, you have a little bit of concern. So you know what, tell you what, let's get another EKG. So another EKG was obtained at 2:35 p.m., so about 10 minutes later. And now, wouldn't you know, all those ST segments that we said were concave upwards in V2, V3, you know, look carefully. I don't know if maybe we're just being overly concerned about this, but it kind of looks like they're getting just a little bit straight, doesn't it? And in fact, down here in V3 also, maybe it's straightened out just a little bit. I don't know. Let's go back and look at the EKG from 10 minutes earlier, and it's clearly concave upwards, and now it looks like it's gotten more straight. You know what? Maybe that's a really soft call. Let's get another EKG. So they did. 2:49 p.m. They got another EKG, and it's still kind of straight in appearance. Maybe, I don't know, maybe a little bit more straight. I don't know. You know what? I'm still a little concerned. I'm not sure whether I should be concerned. Nothing else is changing. The rest of the leads look okay. You know what? Let's get another EKG. And that's what they did. 2 minutes later, they got another 12 lead EKG. So if you have any concerns about the 12 lead, why not just get another EKGs, right? It's a piece of paper and ink. That's how cheap of a test it is. And yet it can give you life-saving information. We say that every week. It's a piece of paper and ink. It doesn't cost very much at all. Okay, I don't care what they charge, but the cost is very simple. It's very little. It's a very simple test to do. Simple, rapid, reliable, can be done at the bedside, and you get your result immediately. It's not like waiting for a blood test, like a lactate level. All right, so anyway, 2 minutes later, they get another EKG, and now I'm not feeling too good about this because now it's almost starting to look like it's bulging just a little bit, doesn't it? It's a very, very subtle looking change. It's starting to bulge outwards, be a little convex upwards. And then the other concern here that hopefully you notice is take a look at the end of that T wave. Okay, let me go back for a second. Now, here's the, let me get rid of all these marks. Here's the initial EKG. The T wave goes up and then it goes like this. But now what you're noticing is that the T wave goes up and then it comes down and there's just a little bit of terminal inversion at the end of that T wave that I'm trying to draw there, that little terminal inversion. Marriott and some other people used to refer to that as an inverted U wave. Now I don't care what you call it, but the key point here is that when the T wave goes up and then down and then back up, and it's just got that little bit of terminal T wave inversion, especially if that's new, that should make you a little bit worried. And you see it there in V2, and maybe it's starting to happen there in V3 as well. I don't know. I mean, what do you do when you're not really sure what's going on? You know what? Let's get another 12 lead EKG. So they did that at 3:06. And now you still see just a little bit of that terminal T wave inversion in V2. And then, let me go back to the first EKG. We've gotten a whole bunch of EKGs. It's always worth taking a look at what you've got now and comparing it to what you started with. So let's go back. Here's what you started with at 224. Take a look at these T waves. All right, nice and concave upwards. It comes down, and then boom, it moves forward. That's what you see in V2 and in V3. Now, what you've got about 45 minutes later, let me go back for a second. Now what you've got 45 minutes later is you've got a T wave that's not concave upwards, but it's straight, maybe almost kind of bulging, and at the terminal part of that T wave is not going up and then down, it's going up and then down, and then just a little terminal T wave inversion there at the end of that T wave at V2, and in the EKG just 2 minutes earlier, also in V3. So there's some T wave changes that are happening right in front of our eyes. I got another EKG just a short time later, and now it kind of looks like the ST is starting to rise just a little bit, Certainly not much at all compared to the EKG that you got a little while. Get rid of all these marks. Certainly not much compared to the EKG we got before. And we've already said that this is just J point elevation that we're not going to worry about at all. But what did I do? Okay, so now we've got a little bit more ST segment elevation. And holy smokes, take a look at lead V4. Lead V4, that T wave is starting to become even more concerning. In lead V4, it's starting to become a bit biphasic in appearance, right? Biphasic T wave. And what do we know about biphasic T waves in the mid-precordial leads? V2, V3, V4. That's referred to as Wellens sign. Biphasic T waves or flat-out inverted T waves in those mid-precordial leads described in the early 1980s by a really, really smart European cardiologist by the names of Heinz Wellens, and we've referred to that as Wellens sign. That is very specific for proximal LAD disease, and we've clearly got that going on in V4 and there's that little hint of terminal T wave inversion out here in V2, and well, V3 doesn't concern us all that much, but V2 and V4, there's some T wave changes that are occurring. So at that point, Sean ended up calling cardiology down. Cardiology came down, they saw the patient, and they said, well, you know what, this is really subtle, and a lot of cardiologists are not completely big-time believers in Wellens, not because they don't think it exists, but because they just haven't learned about Wellens sign. And so they decided to just do a quick bedside echo, and they said, you know what, if the bedside echo is unremarkable, we'll consider taking him to cath tomorrow. And if the bedside echo is concerning, then we'll take him to cath right now. So they did a quick bedside echo, and this was the final EKG, I think, before the bedside echo. And you can see that now the Wellens has progressed into V3, and it's clearly present in V4, and V2 has a little further terminal T wave inversion. They did the bedside echo, and based on that bedside echo, they said, we are not waiting. We're taking them right to the cath lab immediately. And sure enough, as predicted, based on these Wellens findings, the patient ended up with a 90% proximal LAD lesion, and he ended up doing well. And here is another life saved just by reading the EKG, just by getting serial EKGs and taking a look at how the T wave changes can make all the difference in the world. So 2 quick points, just to wrap it up. 2 quick points. When you have, actually make it 3 points. Number 1, when you ever have concerns about a 12-lead EKG, you're scratching your head and thinking, is this normal, or is this just a real subtle thing? Am I just imagining stuff or not? What do? Get serial EKGs. Repeat it in 2 minutes, 10 minutes, 15. It doesn't matter. This is a cheap test. It's a piece of paper and ink, and you get the result immediately. Keep those sticky things on the chest. Use the same EKG machine, same lead placement, and repeat the 12-lead EKG. And if you see something changing, you've got to worry about it. So point number 1, get serial EKGs when there's any doubt. Point number 2, subtle T wave changes can predict impending cardiac ischemia or infarction. When you see that the T wave has gone from nice and concave upwards, or smiley face, as sometimes people say, to straight in appearance, that's a significant change, especially if it's occurring during your shift. And certainly if it starts becoming convex upwards, that's a significant change. You've got to worry about that. And then point number 3, when you see that Wellens, that biphasic T wave pattern in V2, V3, V4, I usually go by 2 out of the 3. If you see it in 2 out of those 3 leads, then that is highly specific for proximal LAD badness, a critical occlusion in the proximal LAD. You know what? If you just Google search Wellens, you'll come up with a whole bunch of articles that talk about this when the T waves are biphasic, or if the T waves are flat out inverted. Well, you know what? I'm not even going to talk about that. Nobody misses those flat out inverted T waves. A lot of people see the biphasic T waves and call it nonspecific. Your computer calls it nonspecific. Sometimes your cardiologists call it nonspecific. It's not nonspecific. It's very specific, according to that literature that's out there, according to multiple people's personal experience, according to this case, according to my experience. And you know, don't believe the anecdote, but believe the literature. That biphasic T wave appearance in those mid-precordial leads, especially when it's new, you've got to worry about proximal LAD disease. And simply by knowing that and getting those serial EKGs and seeing those subtle T wave changes and knowing what to make of the Wellens, they got cardiology involved, and this guy had a critical occlusion in the proximal LAD. This could very easily have been missed, and he'd be dead. People with proximal LAD disease don't often do well. So that's enough for this week. I hope that case has been helpful. And remember, get those serial EKGs and pay attention to those T waves. They can save a life. Thanks, everyone. I'll talk to you next week.